was definitely grossly metastatic because there was coccyx deposits which was seen. So whether labeling or not, it's probably immaterial, or probably one could go ahead and say, do a brainstorming and say that it was already metastatic at that very moment of time. Secondly, with respect to, just wanted to highlight, with respect to treating carcinoma rectums, there's a trial which has come up recently when we are doing far more immunotherapies in these patients, and they may actually avoid surgeries in the long run also. So that has come up very new, and we may actually avoid, because all these pathologies, they tend to have a lot of tumor infection and tumor cells milieu which is there. So all the inflammatory milieu is there, which is a lot of inflammatory milieu associated with these kind of cells. So I think those two things that I wanted to highlight were these only, sir. Right, so thank you.
Yeah, please. Thank you so much.
For 3 years, I think the question which comes to my mind that why did we miss that this patient had relapsed disease? Were we following up with something like whole body PET CT scan, which were not to be seen in this case? What are other things which could have done, which could have caught that disease? So I don't know, like for 3 years, we missed it. It came to me as a big surprise that all thing was just that disease.
Prakash.
I had not been a part of the treating team, but PET can, like Brigadier Partha sir had pointed out, PET may miss lesions in signet ring carcinomas because these are not FDG avid. Generally, what is the modality that we use is contrast enhanced CT scans, which can, and but sometimes they can, if the CEA levels are stable and the patient is doing well, we may not go ahead and give an intervention, because every time you intervene, you're losing one line of therapy, sir. So that is very important. Labeling person is a different thing altogether, but actually going and offering him something would be entirely different, sir. And especially when the patient is MMR proficient, and he does not have any mismatch instability genes, and although repair genes are not deformed. So in that case, the number of treatment options are very less, sir.
If I bring Brigadier Suman's query, if I just it out, I think you wanted to say that there was a ab initio. He was a known case of CA rectum, and from July 21 till September or December 24, 3 years. So if there is it is my query also. So if there is a rising CA and we don't find any in the imaging parameters or the armamentarium what we have, that there is a progression of the disease, the malignancy by itself. Is there any way we can pick it up somewhere? I think this was what you wanted to do.
So, sir, that as of now, if we have a rising CEA, it's equivalent to a serological relapse, and ideally a PET scan should pick it up. In the beginning, you're absolutely correct. If you see the NCCN guidelines, there is no role of a PET scan in T1, T2, T3, N0 disease. We, in fact, advise against doing a PET scan ab initio. To look at METs, that's the only thing available. Nowadays, there are people who are doing circulating free tumor DNA, and we can see those levels, but they're all experimental. And generally, these patients go a regular checkup. I'm sure they would have been coming to one of us for a 3-monthly follow-up where we do an ultrasound, and if he's symptomatic with cough, a chest X-ray once a year. These things would be routinely done.
And sir, if you let me ask another thing. If ab initio, if we knew that it was not only a signet ring carcinoma than a wholly differentiated, would the management would have been something different? Prognostically, I could make out it is quite
prognostically, definitely it's a worse tumor, sir. The bad factors are young age, sacrococcygeal deposits. Then 12 out of 14 nodes is also a poor prognostic thing. I don't know, the CA levels were not mentioned, But were they high? If they were high, then that's a bad
Very high.
prognostic. Very high, then it's a very bad, poor
Not
prognostic
very
sign.
high. If Naresh, do you remember?
It was on more than 200. Yeah.
Started increasing from 2022 onwards.
How much?
And initially, when the first time when it was reported, it was somewhere around 10. And thereafter, it kept on increasing.
Yeah,
It was more than 200. Last report, which
So
was
he's a
reported.
secretor, and that the CA levels are giving us a good mark of relapse. So
So, so I had a point also. The CSF glucose was actually low.
So,
So when we say that signaturing cells are not avid glucose uptake, are we entirely sure about that?
so basically, when there is a leptomeningeal carcinomatosis, the blood-brain barrier is lost. So there is a lot of influx of WBCs as well, along with the proteins. So that can explain the very high protein and a very low glucose.
Any comments? Any more comments from the faculty? If it is not, then I will request Commandant Sir to have his
Just
final
one thing,
thoughts.
Pragya, I wanted to know whether the kidney that you grossed, I mean, that
Sir.
was all fungal infection. What we
So-
saw on the MRI, which Naresh had shown us,
Yes, sir.
was infiltrated with fungus. So
No, sir. I thought that probably since it is invasive mucormycosis, I was expecting mucor within the renal vessels. But even after extensive grossing, we didn't find any fungal elements in the kidney, neither in the parenchyma nor in the vessels. So.
because he was showing the diffusion restriction, the ADC maps, which he was showing, that could be explained both by pus and by fungus.
So we didn't find any fungal elements in that. So.
Thank you, General Giri. Sir, General Rao.
Yeah, I think very well presented and yeah, as rightly brought out by everybody. And in the first surgery, I think possibly the patient had some sort of small bowel lesion also. Nobody with APR has ileostomy and a colostomy. Having both, that means either there was a problem during the surgery or they couldn't remove the complete tumor or some reason they had an ileostomy and a colostomy. So that's a little not a thing to be about to do in an APR. That's first thing. Secondly, the CA levels kept rising. And if you really look at the PET scan reports, it shows some sort of uptake. Possibly they thought that it is post-surgery or possibly some sort of inflammatory thing and left it at that. Thirdly, it was difficult to do a degestanting. So possibly some sort of activity was still going on. And every time they went in and did a degestanting or some sort of intervention to decompress the renal system, they had some sort of problem. So that's the third thing that should have brought to the notice, that possibly some sort of activity is still going on. And fourthly, what I want to bring out is the family history, what he rightly brought out, is why not now go back again and look at the family history, and do we have any role of screening the family members?
Bringing one thing, sir, what you said, that it was difficult for the degestanting to be done. To be very precise, on the left side, the urologist could not negotiate it through the bladder. They had to do it through a pyeloplasty approach. So possibly these are the points of learning, or possibly we should have a more wider approach. If there are no more comments, or I think we can bring a close to this. Thank you, Group Captain Pragya
Thank you.
and Colonel Bansal. Thank you everyone for this, for a patient hearing in this interesting case. Bit longish, I accept it. And thank you everybody.